Well, good day, everybody. This is Chris with the Ancient Skull. I hope this video finds you all doing well. Happy Friday. And I wanted to put a quick video up now that I'm kind of on the road to recovery and feeling a little better. I wanted to talk about some interesting topics. Specifically, I want to talk a little bit about lead aVR, augmented vector, or augmented voltage right. And this is something that is, I think, becoming more and more common. It's been talked about, at least I would say over the last 5 years. This is becoming more common, more relevant, and potentially a little more relevant to EMS and the emergency setting in general. So traditionally, when people learn about ECG interpretation, and this is what I was taught when I first learned multi-lead, 12-lead ECG interpretation, really my first in-depth courses were back in 2006. Was it 2000? Yeah, it was 2006 when I was in flight nurse training, and we were essentially taught that aVR really did not have a whole lot of diagnostic value for the most part. And in more recent years, that assertion has certainly been challenged. So let's just talk a little bit about what aVR is. aVR, augmented vector, augmented voltage right, is it's not an actual lead in the strict sense, in that there is an actual electrode or two electrodes that are actually attached to an actual patient, and looking at voltage differences between those two. It is a manufactured lead, and it really is a lead that is in a sense a kind of a superposition. You take some information from lead one, and you take some information from lead two, and you can kind of create a new lead, if you will. And really what you do is you make a positive and a negative electrode, and the positive electrode is an electrode that is actually attached to the patient. In this case, it is the electrode that is attached to the patient's right arm. So that physical electrode is the positive electrode. But then what you can do is, when you talk about Einthoven's triangle in your limb leads 1, 2, and 3, right? If you can take those using vector summation and put them in superposition, they all kind of cancel out more or less, not quite, but more or less in the center of the chest, right around the area of the heart. And that is what's called Wilson's central terminal. And in that cancel out area, all right, being kind of loosey-goosey liberal with the language, you can actually make a virtual electrode, and you can make that a negative electrode, and we call that Wilson's central terminal. And Wilson's central terminal is then used as the negative electrode for all the limb leads. And so in the case of aVR, the negative electrode for lead aVR is at Wilson's central terminal, and then it looks toward the positive electrode on the right arm in this direction, right? And so that direction kind of goes through, up and through the kind of the back and then toward the superior aspect of the right ventricle and the outflow tract. In that direction. So it doesn't really look at any significant myocardium. It's kind of looking at outflow tracts, blood vessels, right? And so, diagnostically, we often, don't use it, or traditionally haven't used it. When you look at aVR on the monitor, because it is looking up toward the right arm, typically the typical path of depolarization in your heart is actually moving in the opposite direction. The mean vector of electrical activity is moving opposite of right, down into the left, not up into the right. And because of that, because depolarization is moving or electrical activity is moving away from the positive electrode and toward Wilson's central terminal on average, the deflection is typically going to be negatively deflected in aVR. So the QRS complexes tend to be fairly small and fairly insignificant. Negatively deflected T waves tend to deflect negatively, and the ST segment tends to be flat. All right, so that's classically what you see with aVR. However, what can happen is you can have ST segment changes in aVR, particularly ST elevation, when there are certain situations, all right? And when you get elevation in aVR, generally speaking, there needs to be some sort of issue that impacts a large portion of the heart that can then impact these areas that aVR goes through, looks at, if you will. And so there has to be a fairly substantial global issue going on with the heart. In the non-myocardial infarction setting, we can see some abnormalities in aVR in sodium channel blocker toxicity, TCA, overdose, things like that. There are some changes that happen in aVR, but I'm going to focus more on the acute coronary syndrome side of the house, if you will. So what we see with aVR is ST elevation in aVR can become relevant, particularly when you do a 12-lead ECG and you see diffuse ST depression. So you see ST depression in leads on the right side of the heart and the left side of the heart. So you see ST depression in inferior leads, lateral leads, and ST depression in possibly the anteroseptal leads. And so if you have kind of this global ST depression and you also have but at the same time you have ST elevation in aVR, that should be a red flag that you need to think, that should prompt you to think about a couple of different things, all right? And what are those things? So first and foremost, this is potentially indicative of severe coronary artery disease. And not only that, but it has to be a type of disease process that will result in large amounts of ischemia to multiple areas of the heart. So you need to be thinking about multi-vessel disease, right? Severe disease that might impact the right coronary artery, the circumflex, the LAD, right? That can do it. Another thing is if you occlude the left coronary artery high, so you have a higher proximal occlusion above where the coronary artery branches into the circumflex, which goes along the, typically along the lateral, and then in a relatively small percentage of patients, the back of the heart in left dominant circulation, and then the LAD, which perfuses the front part of the heart, the anterior, a lot of the muscle, the anterior wall, part of the septum. If you have an occlusion above where the left coronary artery branches into the LAD and the circumflex, right, we call that left main coronary artery disease, or LMCA stenosis. That, just having an occlusion, a very proximal occlusion or severe stenosis, can also result in a pretty significant amount of ischemia involving the anterior wall, the septum, the lateral wall, and sometimes, again, in some patients, the circumflex can also perfuse parts of the inferior wall, and so you can have this inferior depression as well. So severe multivessel disease or severe proximal left main coronary artery stenosis, you're going to see this pattern of ST depression kind of everywhere. multiple leads that aren't contiguous, and then you're going to have ST elevation in aVR. And remember, aVR normally deflects negatively, right? And so there's something diffuse going on in the heart that is causing the normally negatively deflected QRS and T wave to flip up, and then you get that J point elevation that causes the ST segments to elevate. Another red flag is if you have ST elevation in the anterior septal leads, specifically V1. If the ST elevation is also present in aVR, and the elevation is taller, or there is more ST elevation in aVR than V1, that is also a red flag for proximal occlusion, right? Generally speaking, a proximally occluded LAD that causes OMI of the left side of the heart, typically you're going to get that classic quote-unquote tombstone ST elevation in V1 through V4, and it's so obvious that you don't necessarily need aVR to make the diagnosis, but in some cases you might have more subtle findings, and the presence of more elevation in aVR than V1 you could use that to push you in the direction of going, hey, this is an OMI, this is a patient that needs to go to the cath lab sooner rather than later. All right, so ST elevation in aVR with diffuse ST depression, when you have a fairly high pretest probability of an MI, or you have a fairly subtle ST elevation in your anteroseptal leads, but you have marked elevation or elevation of aVR that exceeds the elevation in V1, that should also be a red flag for it, given a high pretest probability of coronary vessel pathology, of course. That is another situation where you should be thinking about the possibility of severe proximal disease. And then I would say another situation where you can see diffuse ST depression in multiple leads throughout the heart and elevation in aVR is actually more not a type 1 MI where there's an occlusion or some severe stenotic pathology, but you can sometimes see this in more of a type 2 situation. So a type 2 MI is a severe supply-demand mismatch. And I would say the most common setting where you might see this pattern of ST elevation in aVR and global diffuse ST depression is going to be in a person who is profoundly hypotensive and not perfusing, like maybe like severe septic shock, they're really hypotensive, they're hypodynamic, and it's not necessarily the coronary vessel disease, although that could also be co-occurring, but it's the fact that they are so their perfusion is so impaired that their heart is just is diffusely ischemic simply due to the fact that they're so hypoperfused. And you might actually see this pattern in the immediate aftermath of a cardiac arrest where you achieve ROSC and you maybe have had a significant downtime of at least several minutes, most likely longer. So the heart is already very ischemic anyway, and the patient's hypotensive. And so in the resuscitation, the immediate aftermath of resuscitation, you may see this. And that may or may not be due to underlying coronary artery pathology, but it may very well be due to simply the perfusion, the supply-demand mismatch that occurs. And so they take the patient to the cath lab and they may not have significant coronary artery pathology, or it may be coronary artery pathology that then led to the cardiac arrest. So it's not, it's not as straightforward as you might think, but all of this is to say that aVR can play an important role in ECG analysis. And I would say that it's not maybe the primary thing that we look at, but it is definitely something that if we see elevation in aVR and we haven't made up our minds, that elevation paired with other patterns and some pretest probability of what we think might be going on could push us in certain directions and push us to think about certain differentials. So that's kind of how I would conceptualize the use and integration of aVR analysis, at least at the level of a paramedic or a pre-hospital provider, ER provider. There's a little more nuance. If you're an interventional cardiologist and you're looking at a patient, those patterns may kind of trigger you to think about, this is the kind of approach I want to take in the cath lab. Like, oh, I see this pattern. This pattern, suggests that there is left main coronary disease, and so my approach going in, the tools that I'm going to use may favor accessing the left main coronary artery first, based on my analysis of aVR and other findings. But for our purposes, we're using it more to focus us into thinking about, hey, this is a patient that needs to go to the cath lab because they have severe underlying multivessel disease or proximal left main disease, or perhaps this is a situation of severe supply-demand mismatch going on. All right, everyone, that's it. Hopefully you found this video interesting, helpful, and perhaps if there's more interest in this topic, I can actually provide some examples of 12-lead ECGs and point some of these findings out. All right, everyone, take care, and we'll see you in the next video.